Hi, everybody. My name is Natalie Yeadon, and I'm one of the CEOs for Impetus Digital. At Impetus Digital, we have built some of the best-in-class asynchronous and synchronous virtual collaboration and communication tools for the life science companies. We've helped companies across the globe over the past 12 years with everything from virtual advisory boards, investigator meetings, payer boards, medical education, rolling out corporate meetings, and everything in between. But more importantly, we really believe at Impetus that everything starts with a conversation. And from these big, hairy, audacious conversations with the provocateurs, the leading edge thinkers, people tinkering in digital or doing some great things in the digital space and beyond, we can hopefully collectively positively disrupt healthcare. And so I'm really pleased to have one of these provocateurs, somebody who's doing something really pivotal in the digital space and working across the United States with impact across the globe. And this is actually Dr. Donald Rucker. Donald is a board certified physician leader who has a very broad clinical experience and proven national clinical informatics success. So he's actually been able to really successfully merge the science with the digital. And so there's lots we can learn from somebody who has really perfected that, because that is going to become, in my opinion, the new normal in medical schools moving forward. He comes with a really strong scientific, computational, and practical background in both medical computing and decision sciences. So we're going to try to find out a little bit of what that is and how he's been able to apply that throughout his career. He was the co-developer of the first Microsoft Windows-based electronic medical record. So what a great thing to put onto your resume in the world, and the designer of computerized physician order entry modules. He has an MD, an MBA, and a master's degree in medical computer science and informatics, and several years experience working as an ER physician and as a CMO at various companies, including Siemens. He's currently the national coordinator at the Office of the National Coordinator for Health Information Technology, or ONC Health IT. Welcome, Donald. So great to have you on the show today.
Thank you, Natalie.
Awesome. So what a career and what choices. Did you know that you want, what did you want to go into first when you were a little kid? Was it mom and dad, I want to be a physician? Or was it mom and dad, I want to be a computer scientist? How did you figure out what you wanted to do and kind of mixing the science with the computational?
Well, I wanted to be a pilot, but then I got glasses, and I think my mother was happy. Currently, the glasses are being repaired, in case you're wondering. The vision hasn't gotten better, but yeah. And then medicine seemed like a sort of a safe choice. When I got to med school, I realized that American medicine was sort of crazy. Frankly, it was just an extraordinarily inefficient use of resources, and so as literally, I saw that as a first year med student, and so then the question was what to do about it, and I got interested in. So this is now the late 1970s in clinical decision making, and pursued that. When I got to residency, I realized the issue was not lack of decision trees; it was lack of data. And so now, early 80s, the PC had just come out, and the Mac was about to come out, and it was pretty clear that a la Dustin Hoffman in The Graduate, the answer was computers, not plastics in this case. And so that was sort of a little bit of a thought-provoking activity, since I didn't actually know anything about computers. And so I decided to bite the bullet and go to school to learn about computers. And that sort of got me started.
So in your travels, and I guess as you've been merging the two together, what sort of commonalities did you find between medicine and computers?
Well, I think, as everybody in medicine knows, it is a vastly data-intensive activity. And so that is sort of a natural fit for computers. And I would say, in a very broad notional way, we're sort of halfway there in a funny kind of way. So I think we have the data part of it. I think we understand that. We have lots of electronic medical records. We're capturing data. You could argue about what the data being captured, and there's some perverse economic incentives on much of the data being captured. But in a big, broad picture, we've gotten the data part of it. What we haven't gotten, which was really the real part that I wanted to do, and we're still pushing. When I was a intern and resident, what bugged me was the amount of useless activity I engaged in that was, I would call it subclerical. It really didn't require any human abilities fundamentally. It just required automation. And I would say we've fallen way short on automation in healthcare. There are little bits and pieces of it, but the data we have, the automation yet to happen. It will happen one way or the other. When you look at the Internet of Things and the networks and the bandwidth and the tools, it will happen. But that's sort of where I think we sort of are. It's taken way longer than I ever guessed. I had no idea that healthcare would be so economically sticky to the perverse incentives that federal policies have created, that it would take this long. But
Yeah,
what you learn.
absolutely. Absolutely. And we see that in the life sciences space. And when you compare it to other industries, it does leave one scratching their head for sure. So let's actually just talk a little bit about the very first foray, which is something that we probably should consider as being a baseline, which is electronic health records. But we probably still have to consider the fact that not everybody is there yet. So sort of what recommendations, either through the ONC or other sort of initiatives that your organization is creating to really get the last tier, if you will, of the bell curve to fully encapsulate this, so that when you say the data, that we really truly do have the ability to tap into all the data that's available?
Yeah, I think when you look at, let's call it computer and software use by clinicians, I think we're pretty close to complete saturation on some level. The problem is we've sort of saturated it with a very labor-intensive tool, which is the electronic medical record as it sits today. We haven't saturated it with automation, right? We are, as I look around the economic landscape, the only industry that has used computers to make more work for ourselves rather than less work. So it's a somewhat unenviable position to be in. I think we just have to, rethink both the data, and some of that are just straight off incentives from CMS. They're doing some very good work there and have already made some progress to get rid of some of the perverse incentives. But I think, there's way more to be done. And ultimately, both in the life sciences, as you mentioned, Natalie, and in the more, clinical provision of care, we sit where we are because we don't have free markets and market clearing prices, which are the way that goods and services are allocated rationally. That's been known in microeconomics for almost 200 years now. In healthcare, we have administratively set prices. And so while the administrators, a number of whom I know personally, do as good a job as they can, the cognitive range that any federal agency can have is just less than the economy as a whole. And you see this wherever government touches, whether it's the FDA raising healthcare costs in extraordinary ways, whether it's the rest of it. But these things do get arbitraged out. So I'm optimistic this stuff will, one way or the other, get arbitraged out over time. It always has.
Yes, absolutely. So we're obviously in this, we're careening through the last ashes, if you will, of the pandemic. We're all anxiously waiting for this vaccine and the new normal to emerge, like the phoenix from the ashes. And there's many more months of maddening things that are going to be before then. But we have to look at this as an opportunity for data extraction and a series of other things. Part of the issue today is a sense of exhaustion. We hear a lot about physician burnout. Certainly the people who are in the hospitals in the front line, let alone the people who are still seeing patients virtually. But
Yep.
let's actually spend a few minutes on talking about the agony around the administration piece of data collection. What are some of the issues associated with that? And perhaps, how it's impacting what physicians are doing on a day-to-day basis in relation to their patients?
Yeah, so when you look, and this is a very US policy centric answer, so apologies for, a more international audience. So as I mentioned before, because we don't have consumers in control making choices, again, classic microeconomics, consumers use market prices and what's called marginal utility, right? So what is it that I want as a consumer, right? Of course, in our consumer lives, we pretty much know exactly what we want. Maybe too many choices are out there, but we sort of know. In healthcare, we've had to manufacture proxies, policy proxies for the consumer, the consumer utility. And, a couple of these, the big ones have turned out to be fairly shy of the mark, and it's worth thinking about them and then, their impact digitally. So I think the biggest one, just in office visits, are what are called the AMA CPT-4 evaluation and management codes. And CMS is, changing these around, but historically, they've required a very, med student kind of approach to a chart. I assure you, there's a huge difference between a medical student taking care of you and somebody who's an experienced doctor. And what the medical student writes as they're trying to learn is very different than what a doctor taking care of you and trying to get you healthy has to do and document and think about. And so, the documentation requirements themselves need to change. Because that policy has not been adequate to, what is often called the search for value, we have then piled on other policies that could be fixed digitally in pieces. And we're doing a number of things at ONC to help with that. One of them is this whole business of quality measures, right? So people would like to buy quality, right? We all know intuitively things that have innate quality are more valuable. However, how do you measure that in healthcare, right? Because the ultimate test of quality is, mortality. We'd like some intermediate variables before we keel over to let us know some earlier stages in our health, right? Maybe even prevention. So how do we measure that? That has turned out to be an extraordinary challenge to measure. We have come up with these very narrow point estimates of a handful of cherry-picked, heavily lobbied things called quality measures. And we have something there that I think is going to change that. And then there's some other related things like prior authorization, where you say, well, these very expensive tests or procedures, they need this prior authorization. Now that one's sort of a little bit of a double whammy because typically the reason that they're exorbitantly expensive is because we don't have market discipline around them. And in the case of a lot of the regulated things, a huge cost from the regulations that, increase the price by 1 to 2 to 3 orders of magnitude over what it would be in a competitive economy. But the quality measure one is interesting because the ONC interoperability rule we reference the version 4 bulk FHIR standard. For folks who don't know, FHIR is the rapidly increasing healthcare standards thing. It uses the same type of standards approach and communication approach used for every other app on your smartphone, which is a RESTful JSON Stack, you can Google RESTful, you can Google JSON, JSON. Firefest Healthcare Interoperability Resources is a very elegant data standard. You can open it up in Word and understand what is being moved around. And with the bulk standard, we're for the first time in the US under the payment rules where payers can look at data of providers, are going to be able to have a standardized way of putting any form of big data against the patient population that a payer is paying for, and analyzing not just the super narrow, heavily gained quality measures, but the totality of care. And again, whether your favorite tool are some of the, machine learning tools, deep learning approaches, classic statistics, whatever it is that you want, we think those things are really going to put a whole new computational eye on what we're doing in healthcare, what we're getting for our money. We're just at that point. You're going to see a lot of these approaches in the next couple of years. I know at CMS, here, the Center for Medicare and Medicaid Services, they're already starting to explore some of these approaches.
Yeah, no, so this is actually very interesting. So as we all know, at the end of the day, when we start doing systems innovation thinking, when we start thinking about big macro holistic approaches to changing the way workflows or habit formation and all these other complexities of, the Daniel Kahneman thinking fast and slow type of thing, we realize that, of course, that systems ultimately are about people, and people do things based on incentivization. So I know that with ONC, you've mentioned these things about like something like a macro quality payment programs, anything from something that's payment, merit-based to other types of things. So ultimately the idea is to get into that right balance so that we're incentivizing the right behaviors and making sure that these are in sync with the right types of metrics, especially as we start to get into a place of more wellness care as opposed to sick care. Is that the kind of thing that you're talking about, these new types
I mean,
of
spot on. It's,
incentivization?
Natalie, I mean, it's worth thinking about why we don't have more prevention. And the simple reason is we don't really pay for it, right? We don't typically have CPT codes. In the US, if you don't have a CPT code, you sort of can't get paid on an outpatient basis. Because this is all done by third parties, so, a conversation between payers and providers, both of them ultimately have a bit of incentive to be larger, right? As a consumer, you have a huge incentive to shop and buy things for less, right? But we've made the game between two parties who both have an incentive to spend more. So the consumers, if left to our devices, yeah, we'd want way more prevention. And in fact, there are extraordinary preventative technologies that are, I think, grossly underused. For example, you can get a cardiac CT angiogram and know whether you have plaque in your heart. Wouldn't that be a great thing to know before you have a heart attack? If you have some risk factors and really double down on statins. I mean, you can name these examples. You have just brand new in the New England Journal in the last couple of weeks, an ancient medicine called colchicine that has a huge reduction in inflammation and apparently in vascular disease from this study, costing, 2 orders of magnitude more than this ancient medicine should because of, gaming at the, with some of our Food and Drug Administration regulations. So there's all kinds of things that are embedded in the system that prevent prevention. I think some of that is changing, though. I'm very optimistic, as we, get more Fitbits and Apple Watches and Garmin's and devices. I think, we're getting a little bit more knowledge about our biology and maybe more constant incentives to, maybe exercise, not stuff our face, all those kind of things. Though
Absolutely.
I did see cookie sales are up during the pandemic, so maybe we'll put that on your list of things to wait for.
Put the scale on the side until after COVID, right? So this is actually brings up some really interesting points that I just kind of want to linger on a little bit. So setting aside, the basics, we've got electronic
Yep.
health records. We obviously realize there's incentivizations with the right types of billing codes, and do we do wellness versus sickness,
Yep.
type of management. But there's a whole slew of other things that have happened since COVID-19. At that point, a lot of things kind of stopped. And additionally, a lot of things started. So, what that actually means is we saw this groundswell of momentum around the digitalization, and a lot of things that people were very lethargic, or there was a lot of inertia about, which was adopting technologies that a lot of people were fearful of, or didn't want to touch, or just didn't want to bother with. So
Yeah.
in this new space, what is the ONC saying about some of these new digital ways of connecting with patients, including things like telehealth, but also more specifically, the re-engagement of clinical trials and ensuring that these clinical trials are much more resilient beyond just efficiency, to be able to include tools that will enable patients to report their own outcomes. You were just mentioning things like Fitbits or 24-hour glucose monitors,
Yep.
or incorporating the Apple smartwatch, or anything in between. These are new technologies that are scary, but they also don't have codes associated with them. So what is the ONC thinking about this in an accelerated way to be able to manage all of the expectations of the people who are doing all of this in a very rapid format?
Yeah. Clearly, these things need to be infused with digital knowledge, which basically means application programming interfaces to connect up disparate tools and connect them up remotely. Right, that's at the very essence of modern digital. And so ONC has done a number of things. Our rule, which is based on the US Congress 2016 law called the 21st Century Cures Act, requires standardized application programming interfaces, right? So each vendor can't build their bespoke API. They have to code to a standardized API and a reasonably priced API for the core extraction of data. There are other things they can do at however they want, but for that core freeing of the data to the consumer, what is that going to do? We're quite optimistic. The law is designed, our rule is designed in the next 2 years to get that on patients' smartphone, right? So patients have the data under their control, their agency. That's probably going to be the most transformative thing in terms of this consumer choice we've talked about. There are a number of other things. We're working with the health information exchanges to share data no matter where the patient is. Obviously, some patients are too sick, not able to, aren't going to be able to interact in their moment of illness with smartphones, whatever, software apps. We're also encouraging, building up with some funding and some policy, that health information exchanges that can share information with providers. Those have turned out to be extraordinarily valuable in getting the fine structure of the COVID pandemic information there. They've really, I think, performed much better than the mandated digital reports that we've had to start out with, to get a little bit of a handle on it. But because the health information exchanges, unlike the mandated reports, which at the federal level are all de-identified, because the health information exchanges actually know specific patients, they can follow the course of the illness over time in individual patients. So they can know what's the time between when you have a positive test and your test turns negative, or what's the time between a positive test and when you have immunity. What are the relationship between risk factors like race, ethnicity, comorbidities, specific illnesses, specific medications, and outcomes and, very, very granular types of measures. We'll obviously need this to look at how we do with vaccinations, if there are any untoward side effects of the vaccine. Obviously, we hope not, but it is a novel biologic agent. And while some of the obvious side effects might be in our current reporting system, our vaccine adverse event reporting system, VAERS, if there are subtle changes in the distribution of illnesses in the population, in common illnesses, shortness of breath, chest pain, abdominal pain, those types of things, you'll need to really look through that signal very carefully. So it's, the APIs are changing things for individuals. They're obviously being used increasingly to put a surround to telehealth. So it's not just the, patient-doctor visit, but also e-prescribing, which we have, but other things like, consults, referrals, getting the lab results, and then finally looking at population. So it's been a lot of activity here in a very short period of time.
So there's a lot in there. And one of the things that comes to my mind as you speak about this is the question of what is going to be the eventual role of a physician? Because one of the things that's becoming very clear to me is that there could be an overwhelming amount of data from all kinds of sources. And there is, and we're going to talk in a few minutes more about automation and what you sort of see with that. But let's just think for a minute that that's the case. And there's data coming from all over the place. And at the end of the day, you also said something was really important, which is these patient portals, patients having a lot of control over their decisions, their data. Is there going to become a control issue at some point? Because at one point, the control resided with the physician. And also, I'm a big fan, by the way, of somebody named Scott Galloway. He talks about the great dispersion and the fact that we're in this place where people are migrating all over the place, not only within the US, but globally. And these people are moving. Their medical conditions are moving. Who owns that patient? Who owns that data? And how is that data speaking between certain areas, between states, or across the globe? So there's a question of ownership. There's a question of what is the role of physician? Who is that patient if they're not geographically stationed? Say, for example, a vulnerable person in a long-term care facility would be. What is your view on the future of what a physician is and will be doing?
Yeah. Well, obviously a lot of things packed into that question. So I think that, and as an aside, I started my week at 7 a.m. with a global meeting on an international patient data summary, so that patients moving between countries can have a summary. Number of countries are working on this, and we're syncing that up globally, just to let folks know that that I think ultimately patients should own their data. Obviously, you pointed out the more we move, the more that need becomes critical, and patients will control it just the way we control a bank account or a brokerage account or how we spend our time. And these modern tools will allow that to happen, right? You don't have to move a bulky, fragile paper chart. It's just, your smartphone has vast amounts of storage capacity, and it's just a concomitant of, the miniaturization of memory. So you will have that. The APIs will allow you to interact with all kinds of providers in all kinds of settings to do stuff. That does not obviate the role of the physician, I don't think. I think we've sort of looked at the computerization a little bit from the wrong end. So what we've historically, we've looked at, and I'm sort of guilty of the same, we've looked at replacing the highest level cognitive functions of the doctor. I was a grad student in Stanford's AI lab in the 1980s. My thesis advisor was Ted Shortleff, who invented rule-based expert systems, that literally was one of the pioneers in the field. But I think in looking back at it, where computers are best is at the really mundane things, right? At the really low level tracking, not at the highest level of replacing human cognition and pattern recognition and human interaction. So I think we've sort of, just because, well, there's some interesting historical reasons, but just because I think doctors tend to be pretty smart, the ones who go into computing tend to have a little bit of a abstract thinking, thread somewhere in their noggin. And so we've sort of anchored on that, but I think the real wins for the doctors and the patients are frankly on the low level automation. And with the Internet of Things, I think we have that opportunity now. So I see, physicians a lot, there's some things where you think, well, maybe machines will be sooner, radiology is probably the one that springs to mind as the most obvious one. But I think a lot of the other things, the procedural things, I think those aren't in any immediate danger. But the economic landscape will be changed when consumers want those services provided on the consumer's terms rather than on the provider system terms.
Absolutely, for sure. Now, what's really interesting here when we talk about data collection and we talk about the democratization, if you will, of healthcare management in the hands of the individuals with the conditions and, patients or the digital citizen. And ultimately, what really kind of comes to mind is data can be captured in all kinds of interesting ways. We have the ways that we're aware of, the ones that we're sending in through typing, whatever's kind of coming through your mind and sending that forward. We're also having these opportunities in the future with things like ambient biometrics, things that are just passively passing through you. It could be everything from the way you're coughing and then a Siri or an Alexa picking that up and sending the signal to their physician. And so, the sky's the limit in terms of what these opportunities look like. Ultimately, the question comes down to is these data lakes eventually becoming data oceans, but these data lakes, we just heard the other day about a security breach that happened at a governmental level in the US. What's to say that people are really concerned about the infringement on these data lakes? People getting certain conditions disclosed to parties that they don't want to see this. What are some of the things that the ONC is trying to navigate around these privacy, security, regulations to ensure that we're moving forward in a really positive way in this regard?
Yeah. Well, with our interoperability rules, so talking about the patient's right of access under the HIPAA privacy law, that is anchored with what's called an OAuth 2 process, where the patient gets clear warnings and has choices in putting their data on their smartphone. And the smartphone app is effectively required to disclose what they're doing with the data. That is under penalty of law under the Federal Trade Commission. The failure to follow those things is what got Facebook their $5 billion fine and will subject Mark Zuckerberg to criminal penalties if he does it again. So there is that part of it. Obviously there's data exchange allowed under the HIPAA treatment payment operations. That's really between what are called covered entities and business associates. That's stuff that allows your medical bill, for example, to be sent, or some type of data analytics service to work. So that's the strictures of things that are in the medical record. As you point out, Natalie, most of the inferable information about your health has never come anywhere near a medical record, right? By far, the biggest volume of your inferable health is, your smartphone, your geolocation, your accelerometer, your Siri, whatever. So if your GPS says you're going to McDonald's or the liquor store every day versus your GPS says you're doing a 5-minute mile, you don't need to be an insurance whiz to figure out who statistically is a better insurance bet there, right? If your GPS says that you're up and about, you take the stairs versus your accelerometer, says that you're, you've gotten the Lazy Boy Lifetime Achievement Award for not leaving your lounger. Again, all of these things, your credit card, right? Your entire purchasing history. All of these things are, frankly, for almost everybody, vastly more predictive of their health than anything in their medical history, right? You buy a cigarette, right? That type of stuff. So I think we have not while we can anchor and protect the little walled off health parts to a large degree, we have not as a globe come up with, I think, a global understanding of the bounds of modern data analysis. The GDPR in Europe, the Consumer Privacy Act in California are, I think, big efforts to get there, but I would consider the global inference of data about us, which includes health, that hasn't been solved.
So it really begs the question, and again, we are about to go into some of these big antitrust situations in the coming months. But when we think about a company like an Amazon, we've heard that Amazon has just launched Amazon Pharmacy. It's going to be in competition with many large organizations in the US and elsewhere.
Yep.
And that's just kind of the tip of the iceberg type of thing. We're also talking about a company that has more than 70% of households and growing in the United States. And you're talking about all of these purchases, especially when you're thinking about COVID-19, and many of those purchases were being done through that company. Is Amazon going to become the largest healthcare provider, company, partner? What does that look like? Is there fear or is there exuberance?
Well, I'm not sure anybody necessarily has a huge amount of exuberance about Amazon, except maybe their shareholders. But that's for others to determine. Obviously, it's an extraordinarily creatively managed business, and they have scale and scope. But I think when you look in life, focus is also important, those things work to the extent there's a network effect, right? If there's not a network effect, or if it's a separate network, those things don't work. I think some of these things don't, they have some network effects, but there are a lot of other economic drivers there that I think will come in. I think your question does get to the fact that the healthcare system overall is extraordinarily inefficient in what it does, right? I mean, the reason Amazon I'm guessing, I have absolutely no inside knowledge into anything about Amazon, just what I read in the media, but I'm guessing Amazon is looking at the inefficiencies in retail pharmacy, and maybe more importantly, in the quote unquote pharmacy benefits management space, and realize there's a huge arbitrage opportunity in those systems that are efficient and do not provide, frankly, a clear consumer value when you noodle through the costs they engender. They provide a certain amount of convenience to payers, but that's different than would a consumer on their own buy this service. And of course, the answer is no. So Amazon is making a bet that when consumers are offered a choice, a number of them will go to what Amazon is offering. We've seen this in the shift from bricks and mortar to electronic, and I assume that somewhat obviously is what they're looking at.
Yeah, no, I totally agree, but I'm also even thinking further ahead with some of the things you were mentioning. Amazon has people's receipts. They know what people paid for. They know what food they bought. They know when they bought it. So there is possibilities that this becomes the largest healthcare company in the world, in the fact that they will be able to analyze, predict, and be able to partner with things like payers to determine, like you were saying earlier, some of the best people to fit under certain policies, et cetera. So that's why I was asking if there was exuberance or a great amount of fear around that.
I mean, hopefully consumers will have a choice. The other part of healthcare, not to be underestimated, is, and we're pushing the limits of virtualization as we speak with COVID, but we haven't seen the downstream of that virtualization yet, right? We're in this sort of quote unquote honeymoon phase. At some point you need blood tests, you need procedures, some of this becomes sort of mechanical, and maybe the drone robot will do surgery on you, but I'm not sure anybody on this call has to worry about being alive for that day. Maybe somebody very young. So these things have their bounds, and while some of the largest corporations historically have broken up by with antitrust law, Standard Oil, AT&T, you see other ones where antitrust law was not used. IBM comes to mind, though they were sued for antitrust for decades, where just markets replaced them, and you're seeing, and you see that as we move, and so I don't think the entire world will be Amazon.
It's always funny. I always think when I was younger, I'm really aging myself, when I used to watch cartoons back in the day, and they used to always have that little name of the thing that always showed up that said Acme. And everywhere you went, Acme was there. So this reminds me, Acme, or Amazon, is the Acme from when I was younger watching cartoons. Acme owned everything. So anyway, I wanted to come back to another piece, which is really, this new world that we're living in, and the acceleration about what is going to be preventative, or what are we doing to actually therapeutically manage conditions and diseases. We are in an era where we're moving away from the typical chemical entities that have supported life science companies to the echelons of where they are today. And now we're looking at things like digital therapeutics. We're looking at new regulations, and the FDA accelerating whole digital components of their organization, focusing on things like software as medical devices. How are companies, life science companies, hospitals, institutions, ONC, kind of modulating themselves to this new normal, that perhaps the new thing that physicians are going to prescribe, they're going to go into a digital pharmacy and prescribe an app instead of actually a drug, or in conjunction with a drug? What sorts of things are we doing, and what sorts of limitations or stipulations are there right now in terms of preventing this from happening?
Well, so I think the good thing would be if, there's sort of multi-channel, if you will, right? So you sort of combine lifestyle issues with biologic agents, and can time those in ways that address chronic illnesses. And when chronic illnesses start, some of these start obviously nearly at birth, if they're not genetic on some level. So I think you're going to, smart people are going to find over time, they're going to sort out a mix of approaches. I don't think it's going to be all one or the other. In the Cures Act, to allow innovation, to really encourage it, Congress basically said the FDA could not be in the business of regulating apps. Now, again, as you no doubt know there's a fine line on whether these are unattended and whether, they're sort of direct to consumer or learned intermediary. There are a number of boundary conditions here, but ultimately, in a broad brushstroke, Congress did not want the FDA raising costs here and, blocking innovation. So I'm optimistic you will see things. There's still lots of barriers. We've talked about payment. We haven't talked about licensing. I mean, there's still lots of barriers to all of these things that are complicated to address. But,
absolutely. Yeah, no, absolutely.
Yeah,
and so,
yeah.
So one of the things I think was, that you brought up earlier as well too, was this idea of how do we automate some of the workflow that is really saddling the physicians from doing really what they love doing and making things more efficient at the patient physician interface level. And we oftentimes think about the inclusion of robotics or digital entities for the 3Ds, the dull, the dangerous, or the what was the other one? The dull, dangerous, and there was something else, I can't remember what it is. So it would be used for these things that people just don't want to use or do. And so I guess ultimately the question comes down to is, we do basically, when we talk about our daily activities, we flow into basically automaticity. Our brains are very energy depleting devices. We like to do, they're basically, our brains are lazy. We like to do things that are automatic, that are basically habits. And so unless we insert these things, these tools, these ideas into the natural workflow, we read the James Clear book, Atomic Habits, and make it really super easy to do it, 1% step every single day, it's not going to become part of the norm. So very much anything that we can add into an electronic health record or into the workflow of a physician will just make it easier to do. So what is the ONC thinking about? Where are some of these automations going to be included? How are they going to be included? And how are they going to make the jobs of physicians easier?
Yeah, I think I'm not sure I agree with your premise that that's the only way to insert automation. I think you insert automation through sensing, right? I think you instrument the environment and then you sort of interact with that instrumented environment rather than having the inciting event be human brain initiate. Computers are far better at doing an interrupt on a chip than our brains are at doing an interrupt for a new process. Hands down, by zillions or orders of magnitude. It's at the absolute heart of chip architecture. So I think we have to look at, how do we instrument? And if you look at nursing units, I mean, there's been work on smart beds, just location of patients. Some of these things are just very mundane tasks. I was involved, one of the things that bugged me for literally 20 years was the amount of time I spent on phone calls.
Sorry, I just want to interrupt you for the 3Ds. It was dull, dangerous, and dirty. Sorry, that's what I wanted to interject as when you would be doing it. So please carry on.
Okay, thanks. Yeah, so, the
phone call?
So in phone calls, it just bugged me. I spent more time on the phone than I did in patients' rooms. I mean, there's something a little bit thought-provokingly wrong there. And it took me a while to get a hold of the data, but I finally was able to work in an institution where I was able to get in a redacted kind of way, the phone call records of that institution on one of these voice over IP switches. And in analyzing that and mapping it out to cost centers, so that was the granularity I had, was cost centers, but those mapped to nursing units. What I found is exactly what I suspected. So at this institution, major teaching hospital type of operation, their clinics, 10% of the entire FTE time was spent on the telephone. Just think about that. And those calls, right? Each of those is an interruption, right? Because if you're making a call or you're receiving a call, it's an interruption of what you actually want to do, right? So the amount of time wasted that's the lower bound. And when you look at those, my theory was, just based on personal experience, was most of these things in my life as an ER doc are just things like, where's the stretcher, where's the lab, when's the bed ready? They're really finding out about a status variable, like a 1-bit conversation, literally, up or down, 1 or 0 flag on a status bit that I have to interrupt my time, interrupt somebody else's time, find the phone number, blah, 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 to find that out, because we haven't instrumented any of this stuff. Neither the stretcher nor the bed, nor, the full transmission of the lab results. Lab results are changing. And that half of all these calls were under 60 seconds with a median duration of, I believe, 26 or 27 seconds. A 27-second call is very short. It's, hey, Natalie, hey, it's Don in the ER, Dr. Rucker, is the bed on, available? You can't have a long conversation in that amount of time when you figure out how much time it takes to build up and take down the call, hi, thanks, whatever. All of that is what we should be automated, right? If these calls are that simple and that repetitive, that's the target that we should be going after. I think that's the opportunity. And, again, because nobody's actually incented that much to be efficient, right? There's no Darwinian incentive to efficiency in American healthcare. There's a little bit, but not much. But that's sort of where we have to get. And I think we will get there. I mean, the opportunities are too large, and, it'll happen. The same way that apps and software and digital is, transformed, your business of media, music, banking, brokerage, weather, sports. Pick the app. Every business has been transformed. It will happen in healthcare. I'm pretty confident.
I love that you're looking at the silver lining on that. And I think in the last 5 minutes, and I don't want to get super political, but under the new administration that's coming in, under everything that's going on with the, appearance of a new vaccine, and hopefully, things kind of going back to a new normal, what is the big hope that you have? What are you most inspired about? And what is ONC's objective for the year and maybe the coming years ahead?
Yeah, obviously, as a political appointee who's leaving, that's not totally my call to make whatsoever. But when you look at ONC, at least, we've been a very bipartisan agency. The things I've spent most of my time and the agency's time on in the last 4 years were actually started and heavily initiated under President Obama. So the Cures Act, API, information blocking, health information exchanges, where we spent the bulk of our time, the certification program, all of those things were started under President Obama, and we've carried those things forward. I'm guessing that there's plenty, as we've discussed, plenty of work to do on application programming interfaces, plenty of work in getting clinical and financial data to be a more integrated slipstream. Plenty of work on transparency, both on price and the clinical service in healthcare. These have been relatively perennial issues, bipartisan. I'm pretty optimistic that work will continue in these things, but I guess we'll see.
I love it. And I just wanted to leave on that really positive note. Again, I love your inspired view, that you are excited for the future. I think the sky is the limit. I certainly am really excited to see what else happens. We could literally speak to you for hours because there's so many things that are going on and that you're working on. And maybe hopefully we'll be able to speak with you again in another couple of years and see all the cool new things that have come up. But for anybody who's listening or watching this, we will be leaving links to reach Dr. Rucker in case you're interested in speaking with him partnering with him or discussing any issues that you might be having. So please look for those in the show notes.
Yeah,
Also,
healthit.gov is our website, just to put in a plug if you want to read about those things in more detail.
absolutely. So check that out. You can see that also on the screen here. And I also just encourage everybody, if you're interested in these kinds of conversations with key stakeholders, check out impetusdigital.com. We can allow you to speak with people like Dr. Rucker or many other stakeholders in a longitudinal format using both asynchronous and synchronous touch points to help you think through some of your key strategic issues, challenges, ideas, and innovations that are going beyond the pill. So we encourage you to check that out as well. Thanks very much for taking your time, everybody, to listen to our show today. Please subscribe and like so that other people can find our content as well. So we really appreciate having you on, Dr. Rucker. It was an absolute pleasure. Very excited about what you're doing and wishing everybody a wonderful day ahead.